and good evening, everyone. I'm Joyce Matthew Kurian, and a warm welcome to our today's webinar on management of cataract and diabetes retinopathy. Vision impairment caused by cataracts is common among elderly, but surgery can usually restore vision. We also know that diabetes retinopathy and cataracts can develop more easily when blood sugar level remains elevated over a prolonged period. Let's hear from our expert today more about this. Before I move on to our main topic, I would like to give you a brief on Vayah Vikas. Vayah Vikas is a registered trust with a dream to build and strengthen an ecosystem for seniors that empowers the seniors to lead a more productive and meaningful life. We are a community of senior citizens enabled through an online platform with focus on wide range of services starting from legal, finance, health, wellness, and engagement. Moving on, I would like to go over a few aspects on how each one of you could participate in our today's webinar. It would be a 30-minute session by doctor, followed by a quick question and answer session. Each one of you can participate in the webinar by typing your questions in the chat window. We will collate all the questions and ask doctor towards the end of the session. I request each one of you to kindly mute your devices once we start our session. Without further delay, I would like to introduce our speaker for the day, Dr. G.V. Divakar, MBBS, Diploma in Ophthalmic Medicine and Surgery, MS Ophthalmology, and PGD, Medical Law and Ethics from National Law School. He is currently the Managing Director of Divakar Speciality Hospital and Asian Research and Training Institute for Skill Transfer. He is also the Managing Trustee of Divakar Service Trust. He is also the Senior Professor, DNB, and Senior Medical Faculty, Sankara Eye Hospital. He has over 34 years of teaching experience. As a PG faculty, he is a guide for PG thesis for more than 30 PG and MS, and ophthalmology students. Both as a postgraduate and as a consultant, he has actively participated at both state and national level conferences and webinars, and also as a member of the All India Ophthalmic Society. Thank you, Dr. Divakar, for accepting our invitation and being part of our webinar today. Over to you to take us forward.
Good evening, everybody. It's first at the outset, I thank Vayah Vikas for organizing this meeting, which will be helpful for the number of people who are joining. So I think most of you have heard of all these things. What usual problem is there? I think someone is coming.
May I request all the participants to kindly. Doctor, you could go ahead. You could kindly unmute.
Okay, and you can admit the whoever and other participants are coming there. It's on my screen.
Absolutely, sir. We'll do that.
Okay, okay. So good evening, everybody. I'll start my presentation. I think most of you heard about cataract, I think, by this time. And what are the treatment of cataract? What is diabetes? What is diabetic retinopathy? Everything you might have heard. I will briefly tell about important points which we have to tackle. So this is some common cause of blindness, gradual loss of vision. Like cataract is the most common, about 62 to 65% of defective vision in elderly people is cataract. And next is uncorrected refractive errors. There is all the ages. And cataract, glaucoma, and retinopathy, these are the three things which affects the elderly people more when compared to others. First, I will tell about what is cataract and other things. So this is a normal eye. When the central part, it will be black in color like this. But whenever there is cataract, it becomes whitish in color in the central part. So this is a cross section of the eye. The front transparent portion is the cornea, and next to is the anterior chamber, and here is the lens. This lens is transparent, and next is the vitreous and the retina. The rays from outside, they come from the cornea, pass through the lens, and focus on the retina. So if there is any problem with any of these things, any opacity in the cornea or the lens, the right of rays will not enter, and it leads to defective vision due to cataract. So eyes take a camera because when through the lens, the cornea, the rays pass and pass over the pass through the lens and fall on the retina where they get focused. So it is an opacity of the lens can occur. That is called cataract. It is this transparent lens. There are so many causes. The most common is the aging changes. Senile cataract is the most common cause. Next is the diabetics or some other co-factors like some metabolic disorders or diabetes, or sometimes injuries to the eye can also cause cataract. And normally we see cataract in younger children, newborn children also. There is a congenital cataract. So this lens, once it becomes opaque, the light is falling from distance will not, if it is transparent, it will come and fall here. If it's opaque like this, it will fall in different parts like this. You can see here, if the clear lens is there, right, falls on the retina and everything will be clear like this, you can see. But if there is a lens opacity here, there is blurred vision due to scattering of the light on the retina. Like this scattering will occur, and the image will be like this. So this image, if it is lens is opaque, it appears like this. So clear lens is clear vision, as you have seen here. But if it is opaque, the vision will be like this. It appears. It appears more hazy and not so clear. So this hazy image is the cause of any lens opacity. It causes hazy images like this. The cataract progresses with time, causing more blurring because normally starts at the early age. It will be little defective vision will be there. If they come near the object, they can see. But once it becomes more progressive, it becoming complete opacity occurs. They will not be able to see any objects. So this is how mature cataract appears. When you put drops and dilate the pupil and see the central part, it appears whitish like this. But we should not wait till the cataract becomes mature, as in the earlier days we used to tell. Nowadays, when the patient is unable to carry on his routine work or regular work, we can undertake him for surgery. The aim of treatment will be to improve the vision, to increase the mobility and independence, and relief from fear of going blind. These are the three aims of treatment. So commonly is one indications can be work or lifestyle is affected by vision problems caused by cataract. Glare caused by bright light is another problem, and he cannot pass a vision test. Normally, vision test is required for some jobs or some other licenses like that. So he cannot pass the vision test because he's not be able to see clearly. Even with whatever, even if you use spectacles, also they will not be able to see. And sometimes they may have double vision. And there's a big difference between when one eye and the other eye. With one eye is having cataract, other is having normal vision. There will be a big difference in the vision when you compare one eye with the other. And has another vision threatening the eye disease like diabetic retinopathy or macular degeneration. In such conditions, if you want to treat diabetic retinopathy, the media should be clear. So we have to remove the lens, then only we can apply lasers or surgeries we can do. So in such conditions also we have to do cataract surgery. So treatment options, any eye drops are there? No eye drops. No Ayurvedic eye drops or homeopathy eye drops will be effective in cataract. Once it occurs, it will either remain stationary or it progresses further. Spectacles are partially useful in the early stages in some patients only. If it is a central part of the lens, there is a nucleus becomes opaque. Some cataracts, they will improve with -2 or 3 or 4 -4 lenses. but normally it's only for temporary. Till the cataract becomes more opaque, they'll be used glasses. Afterwards, again, it becomes blood, then we have to operate. So surgery is the best option. Surgery involves removal of the opaque lens and replace with the intraocular lens. It's IOL, it's called. There are different types of cataract surgeries. One is manual SACS is made without using any instrument like phacoemulsification. In the manual SACS, a small incision is made in the sclera, that is white part of the eye, about 2 to 3 millimeters from the limbus, that is where the transparent part is joining the white part, and a partial thickness tunnel is made to enter the anterior chamber. Another small incision is made in front of the lens capsule. Normally, lens consists of outer capsule, cortex, and central part is nucleus. And we'll remove all the cortex matter and central nuclear part, everything will wash it out. And IOL is placed inside the lens capsule. And here there's no need of sutures as it closes by itself by self-sealing wound. Since the partial thickness wound is closed by itself. And this surgery is more commonly done in developing countries because it's economically quite cheap, works out cheaper and quite easy to perform. It can be learned fast by any of the surgeons. So phacoemulsification is a common surgery which is done in most of the urban areas, where we use an instrument called phacoemulsification machine. Here only 2 small incisions are made in the eye where the cornea meets the clear covering of the cornea meets the white eye of the sclera, that is white part of the eye sclera. Once 2 openings are made, then we enter the anterior chamber. We'll move open a part for the anterior capsule, or capsulotomy we'll do. Then we'll pass an instrument called phaco probe is inserted into the eye, and sound waves are used to break the cataract into small pieces in phacoemulsification. Sometimes the anterior capsule too. The cataract and lens pieces are removed from the eye using section. There is this is an instrument which you use. Then IOL is placed. Here you can see the here we enter the anterior eyeball inside and remove the first anterior capsular part is removed. The lens is phacoemulsification through the sound waves using this instrument. Will make it into small pieces and it will get absorbed to the same instrument. There are 2-3 tubes in there in this. So we remove this nucleus, then put the intraocular lens. So first it will cut in 2 pieces, then we can remove it easily. Then once all the lens and the surrounding part called the cortex, everything is nucleus, everything is removed, we'll put the intraocular lens inside through the same instrument or through the same incision. Here only 2 to 3 millimeter incision is enough. Even less than 2 millimeter incision now the lenses have also come now. So here though no need of suturing and separation can be discharged on the after 2 to 3 hours of the surgery only. No injection is given, no bandage is required. So this is about cataract afterwards. I'll tell in detail if any questions are there. So once the surgery is done, patient will get good vision. 1 or 2 weeks, they want to apply some drops about 4 to 5 weeks. Or late, sometimes some complications may develop, then it can be treated by laser or some other treatment. So diabetic retinopathy is one more condition. Normally, all over the world, there's 100 million diabetics. About 6% of them are adults. Asia has high prevalence. About 20% of the current global is diabetic population. In India, it's about 39.9 million in 2007. It may double in the 2025, like this 69.9 million. 1 in 5 children have probability of developing diabetes and its related complications in India. So normally diabetes occurs in ocular eye complications are these things: diabetic retinopathy, which affects the retina, the cataract, which I told earlier, like lens can become opaque. Normally diabetic cataracts occurs at an earlier age compared to the regular cataracts, because normally regular old age cataract it occurs after 60 years. Whereas in diabetics, it occurs at 50 years like that, and it's more soft cortical in nature, whitish in color nature. And while operating a cataract in diabetes, we should be careful because they are more prone to infection. So diabetes should be controlled well, and generally we can operate. Then glaucoma is a condition where there will be intraocular pressure is raised and it may cause damage to the optic nerve, causing defective vision or blindness. And optic neuropathy. The optic nerve can become damaged due to the complications of diabetes. So these are the 4 eye complications in diabetes. So out of this, diabetic retinopathy is the most common condition which we come across, which is a microangiopathy affecting the retinal precapillary arterioles and capillaries. The worldwide prevalence is about 4 to 28%, and about 2% of the diabetic population have vision loss. It occurs both in type 1, that is early onset diabetes, and type 2, that is late diabetes, like that. And progression of the diabetic retinopathy is 100% in type 1 and 75% of type 2 diabetics. Over 15 years duration of diabetes will develop diabetic retinopathy. Normally, when the diabetic starts, the old elderly people with type 2 diabetes, it won't occur in the immediate 1 or 2 years. After 10 to 15 years of diabetes, they develop retinal problems that are diabetic retinopathy. So normally approach to the management of diabetic retinopathy will be primary prevention, that is avoidance of prevention of diabetes, of high risk factors like obesity or smoking or alcohol. And we can have health education regarding the control of diabetes will be helpful. And secondary prevention is early diagnosis and treatment. Normally, retinopathy or diabetes, will advise them to come for checkup once in a year, because if you diagnose early and treat, the permanent damage done to the eye can be stopped. Or if the once damage occurs, it is irreversible damage. So we have to prevent early diagnosis and treatment is the most important step we should take in the diabetic patients. And controlling of risk factors like high lipid levels or increase high overweight, all those things has to be controlled. And once the retina is damaged, visual and rehabilitation has to be done, tertiary prevention. So management consists of general management in the control of diabetes and management of non-proliferative diabetic retinopathy. The early stage of diabetes retinopathy, it starts, is called NPDR, where only small lesions will be there, which can be treated easily. And management of PDR means it's a rate stage of diabetic retinopathy, it's proliferative diabetic retinopathy, wherein the blood vessels go into the front into the vitreous cavity and fibrous bands will form and detachment can occur. And management of macular edema. Macula is the most sensitive part in the retina. If the fluids get collected there, then we have to manage that as a separate entity. So when we put the drops to the eye and examine the retina, it appears like this. More clear, there will be no lesions anywhere in the retina we can make out. Normally, we'll examine the retina by using a slit lamp and on the lens is a plus 90 diopter lens, so that we can see the retina inside. There is one more method of examination called indirect ophthalmoscopy. As a patient is made to lie on a chair like this, and with using different instruments called indirect ophthalmoscopy here and plus 70, 23 or 30 diopter lens here, we'll examine each eye separately and chart out the retinal charts we'll write. What are the pictures are there, everything we'll write there. These are some changes which can occur in the early stage. The thickening of the blood vessels can be seen. This is one more instrument called OCT or ocular computerized tomography. Here we can see all the layers of the retina, take pictures of these layers of retina. So this is required because if there is edema, like a macular edema, the fluid will get collected in the retina that can be seen early and detected and treated like that.
So, sorry, sir, for the interruption. So there are a couple of requests that are there from the participants. Some of them are unable to hear you.
Oh.
That's one. And also a request to slightly slow down They're not
Okay.
able to hear you well, I think, because of the connectivity as well.
Oh, okay, okay.
Sure. Thank you so much, sir. Yes, sir. You could
Okay.
go ahead.
Shall I go to the previous slides or shall I go ahead?
Yes, sir. You could go ahead.
Okay. So this is a instrument called OCT, where we'll take the pictures and we can see the different layers of the retina can be seen with this instrument. This is so the layers of retina are seen. There is some fluid collection here. This is the innermost layer called the retinal layer. It's got 10 layers, and here fluid is collected. All this can be seen by using this OCT. So we examine the retina. We'll ask the patient to lie down on the putting eye drops, pupils dilated. We'll ask him to sit on this chair like this, and through this instrument we can see and take the photographs also. Retinal photography can be done using this this instrument. So fundus imaging camera is attached to this instrument so that we can take the photos. One more test is we will inject some dye into the vein and take serial photographs in the eye. When it reaches eye, it appears like this. Normally, to see small lesions, this fluorescein angiography is helpful. So, if once we see the retina, if there are some damages are there, to know the extent of damage, we can inject some dye into the vein into the near the elbow, and once it reaches the retina, we can take these photographs using that fundus imaging camera. With this, we can make out any blood changes are there or any other retinal lesions are there. We can make out using this instrument. Here you can see some. This is the macula area where the fluid does get collected here. So that this can be easily normally with if you see directly without any dye injected, we can't see small lesions like this. There may be a collection of blood vessels or leaking from the retinal blood vessels. All this can be made out by using this fluorescein dye testing. So-called microaneurysms and connection between the two small blood vessels like this. These are the changes which occurs in diabetic retinopathy. Normal retina, it will be, if you do angiography, it will be like first picture I showed, no? It will be clear and there will be no lesions like white dots or black areas will not be there. These are all microaneurysms and hard exudates are there in this. So in the first I've shown the retinal picture where the retina appears clear, there will be no lesions. Here, once the lesion appears, you can see this small dots like these lesions, hemorrhages will appear. This side also you can see hemorrhages here, small dots. So along with the defective vision, if we put a Dobson test, we can make out all these things, and we'll take a picture photograph of all these images because it will act as a prognostic value. Once we take now and after 2-3 months, if we take once more, then we can see how much progress has occurred like that. In such early diabetics, if we do the fundus fluorescein angiography, after injecting the dye, these small lesions can be made out like these small lesions where there is a leak is there or hard exudates are there in both eyes. This appears in early diabetic changes or like this where lesions will appear. Later in the onset, there will be a lot of white dots like this, called a hard exudates. in the deeper parts of the retina, and there are some bleeding spots will be there. Hemorrhages in the retinal layers will be there like this. Hot exudates which occurs near the macula is called diabetic maculopathy. Actually, one more term is used for this. Here is a normal fundus. Here in the macular area, there is a collection of exudates. It's called hard exudates. They are called. So as the diabetic retinopathy progresses, both these hard exudates and hemorrhages, they go on increasing in numbers and size. In the advanced stages, there will be a whole of the retina will be filled with these hard exudates or hemorrhagic spots, or bleeding can occur into the anterior part of the vitreous, the transparent portion. Vitreous hemorrhage can occur like this. And fibrous bands will occur like this in some cases in the advanced stages. In the advanced stage, we can see pictures like this because in front of the eye, there will be a collection of blood causing the vitreous hemorrhage, and we can't see other parts of the retina like this. And later on, the blood in the vitreous can become organized and form fibrous bands, causing from the disc and from the vitreous cavity like this. So in the advanced stages, we do fundus fluorescein angiography, pictures to be like this. So you can see the lot of hemorrhagic areas and fibrous bands and hard exudates and so these are the bands in the retina. We can't see anything clearly, only filled up with a number of bands. In angiography in such patients, if we do pictures will be like appear like this, with number of white dots in all the places. So normally in the treatment of diabetic retinopathy, first is where to manage the diabetes. Management of diabetes is by low carbohydrate diets or whatever diet advised by the endocrinologist or the physician, and by exercises and stress relieving techniques like yoga and other things, and by walking and jogging and other regular exercises we have to do. So we can, by doing all these things, we can control the increase of diabetes retinopathy, and more damage can be reduced using by control of diabetes in the correct manner. So we have to take whatever required medications, either injections or tablets, for as advised by the physician in the management of diabetes, along with the lifestyle changes. And we should tell them to avoid risk factors like alcohol or smoking. We have to advise them to stop or reduce. So regular monitoring of the blood sugar levels, control of weight, control of blood pressure, and exercises. These things are required to control the diabetic retinopathy, more complications and more damage to the eye. Even the diabetic patients, if they are having retinopathy early stages, if we control the sugar levels and if we control the weight and other co-factors, the progression of retinopathy will come down, and we can detect them early and treat them as early as possible, whatever is available. So fluorescein angiogram, we'll use the instrument called the slit lamp. Here the patient is made to sit, and we'll put the fundus camera will take a photograph. We'll put the dye into the eye, and once the dye enters the eyes, we'll take the photograph using this fundus camera. And OCT is other instrument which I told earlier. Patient will be seated here, and we'll take the all the layers of the retinal pictures will become like this. We can take this picture. Ocular computerized tomography, it is called. The OCT pictures will appear like this, the different layers of the retina and different parts of the retina like this. The more damage appears like this, I think it will be for the retinal surgeons anyway, they'll be able to make out what are the damages here. There will be a lot of collection of fluid will be there called cystoid macular edema, like a diabetic macular edema. This is a macular lesion is normally lower down, it appears full with cystic fluid. The more fluid we get collected, the retinal layers will push forwards like this one part here also. So all these small lesions can be clearly made up by doing this test called ocular OCT, posterior segment OCT. So along with the fundus fluorescein angiography, OCT is required in all the cases of diabetic retinopathy to further manage, whether to give lasers or to give surgeries or to give intravitreal injections like this. So once the treatment is given with any of the lasers or anything, the edema, the fluid will get decreased and retina will come back to its normal status. So normally the early retinopathy lasers are used to treat the early diabetic retinopathy conditions. Normally, when the diabetic retinopathy starts with only small lesions in some part of the retina, we can leave it like that. No treatment is required. But if it is that this hard exudation and mechanisms, more of the retina is involved, then we have to do the laser treatment. We have to start some treatment. Otherwise, it will progress further and cause more damage. So laser is used in such patients where the NPD or early diabetic retinopathy changes or non-proliferative diabetic retinopathy, it's called. So this is the laser machine which you can see. The patient is seated here, and so the instrument will put one lens here and put the lasers using this instrument. So in laser, once we apply that, we'll make we'll put drops and dilate the pupil before doing the laser treatment. And once the laser is applied, the picture will appear like this. Small burns will be done in different parts of the retina. These are laser spots will appear like this. So normally before doing laser, lesions are like this. So after laser, it will all lesions will some lesions will disappear. I'll show in the next picture. So this is a pre-laser. It appears like this, and after applying laser in all the parts of the retina, it becomes post-laser. It appears clear like this. All the MRIs will get absorbed, and a more clear retina will be seen. But laser is not so much is with some complications, like it may reduce the field of vision, it may cause more permanent damage to the retina also. So we should be careful in selecting the patients for laser treatment. So some patients, if the patient is not responding to laser, or if the patient is not unable to, we can use unable to use the laser, then we will give some injections called intravitreal injections, wherein we use the drugs inside the inject inside the eye, which prevents the proliferation of new blood vessels and the fibrous bands into the vitreous and all in the retina. There are anti-VEGF factors like ranibizumab. So many different drugs are available that can be injected into the eye. It will prevent the further growth or further progress of the normal blood vessels. Normally, we put some anesthetic drops in the eye and dilate using the speculum, and through the white part, we'll put a needle inside and we'll inject the drug. This is the drug injection. Once you have, it appears like this, then it will progress like this in this condition. We'll inject from the sides. So all this, if you inject the drugs it will prevent the further progression of the blood vessels and into the vitreous cavity and other complications, intravitreal injections. So if the patient comes to us in an advanced stage where we can't do laser and we can't do any injections, then we have to do surgeries. Here, this white band which is coming from the retina will be cut into small pieces and we will fill the vitreous cavity with some substance and vitrectomy, it's called. Vitrectomy has to be done along with detachment surgery. The retina is detached, we have to push it back and we have to put the lasers. So all these bands which appears in the late stage of diabetes can be cut by using that procedure called vitrectomy. After cutting that, we will replace the vitreous with some other substance or like silicone oil or some substance. So prevention of development of diabetic retinopathy is of most ideal. The control of systemic status is more important. Systemic diabetic control is more important. Laser, though it treats diabetic retinopathy, is not free from side effects. It may cause decrease in field of vision or damage of some blood vessels, causing hemorrhage. The vision loss due to diabetic retinopathy is irreversible in 85% and continues to downgrade in 35%. So main thing is we have to detect the diabetic retinopathy at the early stage and treat. Once the damage occurs, no treatment will be helpful. So if you once the patient goes into late stage like proliferative diabetic retinopathy, fibrous bands in the vitreous cavity, even if you operate, patient will get partial vision. They may not get full vision, they may not get. So this is in brief about diabetic retinopathy and cataract, which I have told. I think, are you able to hear any? Some of you
Yes.
them are not able to hear, I think, no?
Yes, I think there was some disturbance with a few, but
Okay.
I think we could hear, Doctor. Thank you so much for the wonderful presentation, Doctor. Now
Shall I
we'll move on to...
Stop sharing.
Yes.
Shall I stop or shall I?
Yes, Doctor. Yes, yes, yes.
Okay.
Now we'll take our first question. We have our first question from Mr. Thomas Verghese. It says, what are the complications that can develop during or after a cataract surgery?
There are a number of complications during cataract surgery. Most common is if the intraocular pressure is not controlled. If the IOP is more, intraocular pressure is more. While doing cataract only, the vitreous can come to the anterior chamber. It's called vitreous loss can occur. And sometimes while passing the phaco probe or some other instrument, you may tear on the iris, causing tearing of the pupillary part and those things, and blood can come out of the iris blood vessels. So the intraoperative complications, the late complications are cornea can become white due to the transplant cornea can become white due to bullous keratopathy. And sometimes there may be cystoid macular edema can occur. The macula, the central part of the retina, fluid get collected, causing defective vision. So first few days they'll be already they'll be seeing clearly, and after 3-4 days they'll be doing decrease in vision. That is due to the cystoid macular edema. That's why we advise them to put some antibiotic with steroid eye drops for about 3-4 weeks or in the post-op period to reduce the cystoid macular edema. They are the most common complications we come across in cataract surgery.
Okay.
There are some 38 to 40 complications. So in that important of all these things are the important.
Thank you so much, Doctor. The next question here is, after cataract surgery, is it necessary to wear spectacles again?
So normally, if your IOL is put, monofocal IOL is put, distant vision will be corrected. We can see distant clearly. For reading, they will not wear glasses. But if there is a multifocal IOL is put, they need not use glass for near vision also. If the every calculation is correct, IOL power calculation, and you have used good instruments and good surgical steps are used, then they will get good vision, no need of glasses. But normally, in most of the cases, there will be some undercorrection or overcorrection will be there. Then they may have to use some minor power of -0.25 or -1 cylinder or spherical lenses. They may have to use. That's all. No glass are required. Only if the monofocal or single focus lens is used for distant, no lens is required. Only for reading they have to use glasses.
Doctor, there's a request that says, please throw some light on different types of ICL and what do you recommend?
The different types of intraocular lenses are different types. One is monofocal lenses are there, and multifocal lenses are there, and foldable lenses are there, rigid lenses are there. So normally this foldable lenses only 2 mm incision is enough, but that is a little more expensive actually. So if the patient is affording, they can put this foldable lenses. It costs about 45,000, 50,000 like that. Whereas monofocal lenses, they are quite cheaper. It's about 20, 30,000. We can do it. 20,
Sure.
15 to 30,000. Yes.
Sure. We have Ms. Jayashree who has raised her hand. Ma'am, you could kindly unmute your and please go ahead ask.
Doctor, I would like to know, one of my relatives, she's got some problem due to diabetes. She cannot see, उसको दो चीज दिखती है.
Oh.
At a time, दो दिखता है उसको, and her eyes have started closing.
Normally, in the diabetic patients, the nerve palsies are common. So if there is some muscle palsies, one eyeball movement will be normal. Otherwise, you will not be moving in the same direction. So they will develop double vision. So you have to bring the patient to the doctor and see what is the problem and control of diabetes. And for the nerves in the early stage, we use some exercises if the extraocular muscle nerve palsy is there. If within 6 months, if the nerve palsy is not recovered, then we have to do some minor surgery has to be done to correct the nerve muscle palsies and make the muscle more strength.
Okay. Thank you, doctor.
Thank you.
Yeah. The next question, doctor, is can glaucoma be cured?
The glaucoma in the and there are so many advanced surgeries are there. So we can control the IOP and putting the eye drops also. In the early stages, if we can try with eye drops only, but eye drops are applied for lifelong actually. So to prevent that, we can do some procedures. So if you do surgeries, you can control the glaucoma progress. But once the nerve damage occurs, optic nerve damage, we can't reversal of the nerve damage cannot be done. So we have to detect early and we have to treat early. That is the main treatment, either medical or surgical treatment.
Okay. We have Mr. Bhagwan Das who has raised his hand. Sir, please unmute and you could.
Doctor, when you are supposed to undergo a cataract treatment, that is when you are saying it is blur, totally blur, or just, power changes also have to be taken into consideration.
It depends on the occupation of the patient. So if the patient requires clear vision for the routine work or routine movement, in the olden days, we used to wait till it becomes more white and mature like that. It's not required. We can do it at early, even if the patient is having quantity loss for 2 lines, we will operate now because instruments are quite good and microscopes are available in the higher end, and we can see all the small fibers of the retina also, lens also. So no need of waiting till it becomes more blurred like that. If a patient is able to manage, like if the patient is a villager working in a farm like that, they may not require so much accurate vision. So we can leave it them and operate till when it becomes mature. But if they want to drive a vehicle or if they want to do their routine work, we can operate at even a lesser 6.9 or 6.12 is the vision which we measure. 6.6 is normal vision. If it becomes 6.12 or 6.18, also we can do the operation. No need of waiting till maturity.
Thank you.
Depends on the profession of the patient.
Why are the doctors very in a hurry to take a cataract surgery? Because I remember some 5-6 years back, they said it is the beginning of cataract. So which is the beginning, which is the end, and what is the thing? There is no problem on the vision, has it?
Yes,
so how do you assess?
Normally we do the vision test. If the patient is most of the doctors will check if the patient is able to see clearly, some glaring will be there. Even the vision is clear, even if they're able to see the lost line, if the vision is blurred or some defect problem is there with their work, But no, so many doctors nowadays they do it because it is better to get it early because they should appear like normal vision will continue. They need not decrease the vision due to cataract. It may not hamper their work, so they may continue with the routine work. So most of them will wait, do early stages only because in the olden days we used to wait till it becomes more white color or more mature like that. It's not required now. If the patient is willing and he wants to undergo surgery, we can do it off. No problem.
What is the comfort zone with the cataract, without the cataract surgery?
I think without surgery, if you can manage your routine work and life, it's better to leave it without surgery only.
That's
Yes,
what I
yes.
keep telling the doctors, that I don't have a hurry. They say, no, it is beginning. When 5 years, how long does the beginning last?
Normally, it is become stationary cataract in most of the
Audio
patients.
is not available.
Oh.
Please see this. Unmute.
Normally, this stationary cataract means it comes up to one level about 5 to 10%. It will stop at that way. It won't increase further. Then no need of any surgery. I think we can leave it like that.
So the comfort zone is better without surgery.
Yes, without surgery is better. If you can manage your routine work like seeing TV or reading mobiles or books, it's enough actually. Yes.
That way, no hassle about all these problems. I don't have any problem. Only
And then
power
you can-
changes there. Power
Only
changes, slight power changes there. I got it done.
that you can do, I think. Power change you can do and continue with spectacles.
Okay. Thank you, doctor. That's all I wanted to clarify. Why people are in a hurry to
Yes,
get you operated.
Yes,
That's nice. That's really nice, Doctor. It's a relief for so many of us.
yes.
Yeah. Doctor, our next question is from Mr. Raymond Saldana. It says, what are the symptoms that will be experienced that, when should we go and get our eyes tested for cataract? What are the symptoms that a person would experience?
Early symptom is defective vision. Normally, we will be able to see clearly all the distant objects, everything. But when the cataract starts, there will be a gradual decrease in vision will be there. It may not be sudden loss of vision. The gradual decrease in vision will be there, and we have to go near the TV to see the TV screen, or you may not be able to see distant objects or distant letters like that. There is a gradual loss of vision, a first sign. Sometimes some patients with cataract will come with history of seeing double vision. That is, the cataract is maturing. They may see one or two objects like that. Double vision, it will be difficult to drive and other things like that. It will be difficult. So most common symptom is so better to come for checkup when you after 50 years. It's better to have eye checkup once in a year, and your doctors will find out whether you got cataract or not. And if there is frequent change of glasses, like -1 is there, it become -2 or -3. There is some changes of frequent change of glasses, also indication of some development of cataract. So all these are the early indications of cataract surgery, and it's better to, after 50 years, better to check with ophthalmologist once, and we'll check the intraocular pressure, we'll check the retina, we'll check the cataract is there or not, whether it's progressing, everything we'll check, and then we'll advise them accordingly.
Thank you so much, Doctor. Just one question I would want to ask. When you said once a year after 50, it is advisable to visit an ophthalmologist once a year. If I have diabetes, would that frequency change, or I still keep it at, if I am already, I have blood sugar, does that frequency change, or do I still keep it as an annual visit to the ophthalmologist?
Normally, once the diabetic patients will see the retina. If there are no changes in the retina, they can continue yearly once. But if they develop any retinopathy changes, early diabetic retinopathy changes also, we will ask them to come more frequently, because once in 6 months, depending on the degree of damage in the retina, we will ask them to come once in 6 months, or once in 3 months, or once in 2 months, like that.
Sure. Thank you, Doctor. Ms. Geeta, you had a question for us?
I wanted to ask, I'm seeing white light spark in my left eye, mostly during the night time. What should I do?
The both eyes or only one eye, I think, no? One eye you will see
Only
the...
one left eye mostly.
Mostly it may be early stage of cataract. You're not diabetic or anything, no diabetic or
Yes, I'm
hypertension.
diabetic.
So how many years of diabetes?
Around 15 years.
So I think better to have a full retinal examination. Please go to an ophthalmologist. They put drops and see the retina. Normally, this early indication of retinopathy. They are seeing white layers or black spots or some flashes of light. All these are early signs of retinopathy, diabetic retinopathy. So better to have a retinal checkup once in detail. And if there are some lesions in the retina, we'll put some dye and take the photographs, as I told earlier. Fundus fluorescein angiography we'll do. With all these things, we'll diagnose any damages there or not. Then we'll advise accordingly.
Okay. Thank you, doctor.
Thank you.
Mr. Parthasarthi, you had a question for us? So we have one more question in the chat. What is the usual age that cataract happens? At what age?
Normally, if the patient is not having any comorbid conditions like diabetes or overweight like that, or hyperlipidemia, it occurs after 60 years. It develops about 55 to 60 years, after 60 years only. But if the patient is having diabetes or some other metabolic problems, it starts at early age. It may start at 50 years or 45 years like that. And it develops faster in diabetics when compared to the old age cataract. In old age, cataracts slowly develops and sometimes it becomes stationary. It may not progress further. Whereas in diabetics, progression is fast and it starts at early age. Progression is fast and we have to operate at the early stage.
Okay. We have one question from Mr. Parthasarthi. It says, when I can decide for surgery, my doctor told me if you want to do it or if you manage also, it is okay. Is that what he says? You can manage also without it.
Without surgery, no? As I told earlier, it is better to, if you can't do your routine work, you can undergo cataract surgery is better, because if you can't see clearly or if you can't do anything is blurred, if it is hampering your routine work, you can undergo surgery. Or if you can manage with the whatever vision you have got, if you are able to move about, if you can read and write, regular work you can do, better to wait for some more time.
Sure. We have Mr. Narendra who's raised his hand. Sir, please go ahead.
Sir, I wanted to ask regarding the night vision for when driving the car. It's does it happen to everyone, or it happens only to me? Because I can drive in the day. I'm a diabetic. I can drive in the day, no problem. I can see the near vision as well as the far vision and signals and everything. But during the night, I find the lights coming from the opposite side. It gives a discomfort to my eyes, and sometimes I feel difficult in driving. So
normally in the night, the pupil is more dilated. So if the part of the lens is partially opaque or early lens changes are there in the periphery, it will cause the glaring of light will be more. So better to come for checkup once, and we'll see the retina, lens and the retina. And depending on your age, we can decide whether operation is required immediately or we can wait. What is your age, sir?
My age is 66, but this problem
from facing from long time, I think. Hello?
When I was not diabetic or anything.
Since
my young age, and I have gone through a lot of eye tests also, and nothing was found. So I just wanted to know whether it is related with any of this cataract or retinopathy, because I have gone through eye tests also, and nothing was found. But still, this problem persists.
The glaring is mainly due to the pupil dilatation more in case in night. So early lens opacity, the peripheral part of the lens will cause like this. So better to avoid night driving, or you can go to the ophthalmologist. They will check any other problem is there in the eyes. Then they will advise.
Okay, sir. Thank you.
Thank you.
We have Mr. Nageshwara Rao. Yes, sir. Please go ahead. You could kindly unmute.
Sir, respected sir, I got two
Ah.
questions. One
Ah.
is I am getting thread-like structure from my eyes, and I am using MIST Misty C drops.
Oh.
Is it sufficient, or I have to go for a, this is a doctor's advice, not my personal advice?
Okay, okay. I think that is enough, sir, because of dry eyes, no, that some mucus secretion will be more in the eyes. In the whenever eyes are dryness due to some other causes, if you're not blinking properly or the blinking rate is reduced, that drops is sufficient. You can wash your eyes with cold water 2-3 times and apply the eye drops. That is enough. No other drops is required.
Sir, another question. This is confusing.
Okay.
I am visiting my doctor because I am a diabetic patient every 6 months or 3 months for eye checkup.
Okay.
When I reach the doctors, most of the doctors are saying that cataract is not there, but 1 or 2 doctors are saying you are having cataract and you have to force it to go cataract. What is this confusion I am getting? The visibility is, everything is okay reading. In the morning only, just after wake up, when I go to reading the paper, just double vision is there, some for 1 or 2 minutes, then I will, normally I will read. So why I was not able to get proper judgment to go for cataract? Sorry to comment, but the things are going like that.
Because even if there's some doctors who have got higher end instruments, they will tell even if the early cataract is there, only 5% of the lens is opaque, they will tell you got cataract, you have to get operated. Some doctors, they will wait till more cataract develops and they will tell you have to get operated. And since it's not causing any problem to you in your routine work, routine daily work, you can wait till it becomes more opaque. So
because I have visited Max Vision and also known doctors. That's my problem.
Okay. Okay. So you can leave it like that, sir. If you can manage without any glasses, without any problem, better to wait some more time.
Oh, thank you very much. Thank you very much.
Thank you.
Thank you, sir. We have one question from Dr. Vasanta Malik. Kindly, sir, kindly tell us the prognosis of retinitis pigmentosa. Can diabetes develop RP?
Retinitis pigmentosa is a congenital problem. It is because the retinal pigments will appear and it starts at about 20-25 years and it progresses and the whole retina becomes filled up with pigments and there are night blindness. Daytime they'll be able to see clearly because the central cone part, the central part of the retina is called cone, which is responsible for day vision. So they'll be able to see clearly in the daytime. With the night times, the peripheral part of the retina, which contains a number of rods, they get affected. So that is called retinitis pigmentosa. Since it's a permanent damage, it's irreversible and night blindness is the most early sign. Later on, it may become small vision, like tubular vision can occur. And diabetic retinopathy, if it may not develop because it's already like doing laser in the eye, the pigmentosa, so much pigmentosa has caused damage. So diabetic retinopathy may not be seen. But if the patient is diabetic with retinitis pigmentosa, they may develop retinopathy also. For that, laser is helpful, but it's for pigmentosa, there is no treatment. It's a permanent damage.
Yeah, in this case, doctor, she's mentioned that the patient is a 37-year-old male diabetic for the last 5 years.
So I think better to have a regular checkup once. If we see any retinal lesions due to diabetes, we can treat it with laser or intravitreal injections. But for pigmentosa, there is no treatment as such.
Sure. Yes, we have Ms. Geeta. She's raised her hand. Ms. Geeta, kindly unmute and you could go ahead and ask your question. Ms. Geeta, you are on mute. Yes.
Am I audible?
Yes.
So much for your patience time. I have 2 questions, one for myself and one on behalf of my husband. I'll ask his question first. He's 70 years old. He had his cataract done about both eyes about 10 years back. And at that time, he was told that
Ma'am, sorry, we've lost you.
said it's come again, and he's having this. Hello.
Hello.
Yes,
Hello.
we could.
Now we can hear you.
Yes.
I'm asking a question on behalf of my husband first.
Okay.
He's 70 years old, and he had cataract done in both his eyes.
Okay.
And at that time, they had said that the cataract won't reappear, it won't come back again, but now it's come back again. And he's having floaters also, and he's having because of this vision problem. Like, does it happen? Does he have to go for cataract operation again? And can these floaters be removed?
No, normally we'll when we do the the IOL surgery in the cataract patients, we'll leave behind a part of the lens called a posterior capsule. The posterior capsule can become open. This posterior capsular opacity can occur. Normally, cataract won't help. Only the part of the lens called the posterior capsule, it becomes white in color with the multiple fibrous bands. With the laser, it can be removed. That opening can be made in that posterior capsule opacity. With that, it will be removed. No need of doing cataract surgery again. If with the laser it's not able to remove, then we can do a small minor procedure and pose an instrument inside and remove that opaque part of the lens or the posterior capsule. Then it will be clear. Vision will be clear.
But can we suggest this to the doctor when we go? Can we tell him do laser instead of cataract? That might offend the doctor, isn't it?
No, YAG laser, one laser is called YAG laser. With the YAG laser, they'll be able to make the opening. But I think if it's quite thick, it's not, it can be removed by the laser, then they will advise surgery, I think. You can ask the doctor once. Any choice of laser is there, you can ask.
Doctor, does the floaters vanish after the cataract is done?
Yes, after that capsule is removed, the floaters will vanish because that will do all these problems. Posterior capsular opacity. This is common complication in rate complication of IOL cataract surgery.
Okay. And doctor, one more question from I'm a diabetic, severe diabetic doctor, and I have both my visions are lost. And I've been told that my optic nerve is damaged in one eye. And on the other eye, doctor, I have a very slight trace of light. Like if a tube light is switched on, I can make out that there is some light there. Is there any scope for any improvement, at least in the left eye where the vision is there, trace of light is there?
Normally, the optic neuropathy is the irreversible damage. When the optic nerve is damaged, the damage cannot be reversed. But in the left eye, there is some vision is there. There we have to see what is the extent of diabetic retinopathy damage in that eye. Then we can advise any surgery or laser or intravitreal injections. With that, it can be recovered, I think. Better to have a complete examination with nearby ophthalmic surgeons or retinal surgeons. There is separate specialty in the ophthalmology called the retinal surgeons. They will see once and they will examine. So better to get an opinion of the retinal surgeon.
Okay, doctor. Thank you so much.
Thank you.
If we have some more questions, you could kindly unmute or raise your hands and we could, or you could also post the questions in the chat window. We have Mr. Yes, sir. Please go ahead.
And the hand, and the hand, and the mute for nature. Mute for nature.
Mr. Parthasarthi, you had a question for us.
He was there in the earlier time also, I think, same.
Yes. Sir, do you have a question for us?
This is Narendra again.
Yes.
I just wanted to continue with my question of the night vision. There are some advertisements regarding night vision goggles. So, doctor, do you advise them, or they are of no use?
I think they are of no use. I think no use of night vision goggles, because it's only LOB lenses they will give. Even that also better to avoid. Huh? There will be no use of night vision glasses.
Which stops the glares coming from the opposite side. From that point of
It
view,
may be anti-glare coating they will do for the spectacles. Some people will be improved with that. That ARC coating, anti-reflection coating lenses are available. That you can try for some time, about 6 months. So that may be little helpful. Huh?
so do the doctors also recommend that? I mean, that can be tried.
For some drivers in the profession, we will advise them to wear the ARC coated lenses, glasses, playing glasses. With
Okay. Okay, doctor. Thank you, doctor.
Thank you.
Yeah. We have one more question in the audience, doctor, from Mr. M.V. Rao. Says, whenever I wash my eyes, I feel like rubbing my eyes for a minute or two. I am diabetic. What could be the reason for this itching?
Itching is the main problem. Itching is the main problem in the patient.
Yes. Whenever he washes his eyes, he
Oh,
feels like rubbing it or itching it for 1 or 2 minutes.
because diabetics are more prone to minor degrees of infections or some allergic from outside. So that may be the reason, because some people are allergic to the soap or whatever solution we use while washing the face. So that may be the reason. And if the itching is more, or if there is any redness in there, or if there is some body substance at the red margins, then we have to advise some treatment. Otherwise, no treatment is required. Huh?
Any other questions from the audience? You could please unmute and ask your question. Mr. Parthasarathi, you had a question for us?
There is one patient is asking, what should be the gap between the one eye operation and the other eye operation?
Yes.
Normally, within 2 weeks, we can do both the eyes. Within 1 week, at least 2 weeks is better to leave, because both eyes, some surgeons do, but it is not advisable to get both eyes surgery done at a single time. It is better to wait for 2 weeks. One eye operated, and after 2 weeks, we can get the other eye operated. But in some conditions, if both eyes have mature cataract, then we can do within 1 week also, we can do with suitable precautions. So better to wait for 2 weeks at least. Huh?
Okay, thank you.
Thank you.
Hello, doctor. The
Hello?
white spark that I'm able to see, can I put any drops or anything by which will it get cleared?
What time you will see that white dots, white spots?
Mostly in the night time I'm seeing. Daytime I don't get it.
Okay, I think the drops may not be useful, because white ring-like circles you see, or only dots you will see?
No ring, no light. It's just a spark, like the thunderstorm spark we see.
Okay,
Like
okay.
lightning spark we see, like that in the corner of the.
Drops are of no use. Only if you have got hypertension or diabetes, it has to be controlled. And any spec. Once you have gone to check up with ophthalmologist nearby, eye doctors, I checked.
Yeah, I'm going for checkup.
Once you do the retinal exam, if the retinal small tears are there, some lesions in the retina are there, it may cause like that. If they examine, if it is say normal, then it is better to leave it like that. No need of any treatment.
Okay, thank you, doctor.
Thank you.
So, doctor, this is related to the previous question that we had. He says, when I wash my eye, I feel itchy. So it says, can it be because of dry eyes?
Dry eyes, mainly burning is the main symptom in dry eyes, and we advise some lubricating eye drops, and it's more common with those who are exposed long term with the computers or laptop. Blinking rate will be less, they will get dry eyes. So it may be some low grade of allergy or low infection grade, like that only, I think.
Okay. Any other questions from the audience? Okay. Since we do not have any, I would like to thank Dr. Divakar for being here. Okay, we have one more question. It says, what are the precautions or exercises to improve vision? Reading the Shell chart, last few rows are dimmed.
Okay. I think if the eye exercises are there in the yoga, they will teach eye exercise, but it won't. It will only relax if there is some say muscle spasm in the eyes. There axillary muscle spasm. It will be relieved, and they'll be able to see clearly. It's called spastic myopia. It's called that. It's due to the muscle spasm. They will develop. They're not able to see clearly. That will be relieved with eye exercise or yoga exercises. If it is not relieved with that also, then you have to check your eyes once any spectacle is required. You have to check the glasses, and if you can wear the glasses, it will be clear. The Parsarthi has asked that question, I think, yes.
Yes. He says when he reads the chart, only the last few letters were dimmed.
I think if you are better to get the glass correction once, because the exercise may not be helpful, because temporarily they may relieve the spasm or relieve the this one. Better to have the spectacle, they use the spectacles better. Huh?
Thank you. Yes, sir. We have one more question. Mr. Chandar, you could please unmute and ask
Good
the
evening,
question.
doctor. I have one small question. I underwent cataract surgery 3 years ago. At that time, my doctor said the other eye has got age-related macular degeneration.
Okay.
Is it reversible? I mean, is it curable, doctor?
Yes, sir. If you detect early stages, we can do the lasers and treatment. The age-related macular degeneration is called ARMD. If we detect early, we can give some lasers and can be treated. But once it becomes more in lesion is extensive or more, then it will be difficult to operate. Lasers are available in most of the centers nowadays for this macular degeneration. Since the degeneration, once damage is irreversible, but we can prevent the further damage or prevent the further progression of the ARMD lesion.
I mean, I am 72 years, doctor. What he advised, he said, we'll see, like that. And he prescribed Novaret Neo, which is antioxidant. It is more of a supplement. Is there any other direct medicine for this, doctor?
Systemically, we advise some B complex and vitamin E or antioxidants like what you are taking. But that may be of not much use, because some cases it may delay the further progression of the lesion. So if he is able to do, the doctor is able to do some treatment for laser treatment, do the fluorescein angiography, and there are two types of ARMD. One is for wet ARMD and dry ARMD. Dry ARMD is not suitable for any treatment. Whereas wet type of ARMD, we can treat it with this laser treatment or some drugs.
Okay, thank you very much, doctor. Very
Thank
kind
you.
of you.
Thank you.
Any other questions that we have? I think we can take one last question if there is. Since we do not have any questions, and I'd like to thank Dr. Divakar for taking time off and addressing our members. It was great having you here, sir. Thank you so much for imparting knowledge to all of us. In case our members do have questions that could not be addressed today, you can always write to Vayah Vikas. Please do not forget to fill the feedback form. It keeps us motivated and also, bring out more webinars like this. We'll post the recording of this webinar on our website shortly. We do have a few other sessions lined up for you in the coming weeks. Hope to see all of you in those sessions as well. I once again would like to thank Dr. Divakar on behalf of Vayah Vikas and all our members who have participated today. If you have friends and family who would like to be part of Vayah Vikas, kindly encourage them to register with us as well. Thank you so much for today's presentation. Have a great evening. God bless. Thank you. Thank you, Doctor.
Thank you all. Thank you all the delegates, participants who are here, and thank the Vayah Vikas, Joyce and other people in the Vayah Vikas. Thank you all very much.
Thank you so much, Doctor.
Thank you.
Thank you.
Thank you.